Hi everyone. So today I'll be discussing the OBS and Gynae questions of INICET May 2022, and yet again we can see that there are loads and loads of questions being asked in OBS and Gynae. So out of a total of 200 questions, there are 20 odd questions coming from OBGY itself, and I must say that it's a very scoring subject. So let's look at the questions. They're not difficult. They are from the routine topics, things that we have discussed in class, and common things we talk in class. Yes, there were a couple of odd questions as well, we'll see, but I don't think they're rank deciders. है ना? Chalo, let's go on to the question. So this was a question where you are investigating the male partner for infertility, and he's found to have hypogonadotropic hypogonadism. So you were supposed to tell which of the following are associated with this condition. So it was a multiple completion type question. Multiple completion matlab, we've given you multiple options here, and option A would say that 1, 2, 3. Option B would say 1 and 2 are correct. So this was like a multiple completion type question. Yes. So now let us see what is the correct terminology. So now when you use the word hypogonadotropic hypogonadism, yes, what do you understand with this? So hypogonadotropic means the levels of gonadotropins are going to be low. It itself tells you. So the LH and FSH levels are going to be low. Yes. Now, if LH and FSH levels are going to be low, what will happen to the testes? There's going to be no stimulus to it. So as a result of which, the testosterone production would also go down and spermatogenesis will also reduce. Yes. Which means what else will you see? You will see, or you can see azoospermia, or you can see severe oligospermia. So that is also going to be seen. And as I said, there will be low levels of testosterone. So all these are associated when you talk about hypogonadotropic hypogonadism. Also, please remember, so here, you will include azoospermia, you will include low LH, low FSH, you will include low testosterone levels. Yes, so those would be the ones that will be included. Now, please remember, in general, the most common cause of infertility in males, right, is not actually, transport disorders. It is primary hypogonadism. Do you understand what is primary hypogonadism? So primary hypogonadism means the defect will lie in the testes itself. There are problems of spermatogenesis. So when you say primary hypogonadism, so please remember here, the testosterone levels will be low because the testes is not functioning properly, and as a result of which there is no feedback inhibition, right? So there will be high levels of LH and FSH. Okay, whereas hypogonadotropic hypogonadism is what is referred to as secondary hypogonadism. Okay, chalo. Which of the following coagulation factor decreases? So again, simple things, we know they are being asked, the topics are important. So please remember factors 2, 8, 7, 10, 12, ye factors are going to massively increase in pregnancy, right? So it is actually 11 and 13 which decrease. Okay, so here the answer is going to be factor 11. Again, something that we've routinely done in the classes. Also, please remember that pregnancy is a prothrombotic state. So as a result of which, what is going to happen? The coagulation factors are going to increase. So there is increase in the coagulation factors. At the same time, there is going to be a decrease in the fibrinolysis. So fibrinogen levels massively increase in pregnancy, and that is why you also see high levels of ESR as well in pregnancy. Yes, there is also increase in the platelet reactivity. Okay, so reactivity of the platelets is also higher. There is a decrease in the levels of protein S. Whereas when you talk about protein C, the levels are generally unchanged, but protein S is going to decrease, and the von Willebrand factor is going to increase. So in general, it is a prothrombotic state. Okay. Now, which of the following is not a criteria for preterm labor? So among the options given to us, this is a completely true statement, right? So if a lady is getting 8 contractions in 60 minutes, or we say she is getting 4 contractions in 20 minutes. So a lady who is getting 4 contractions in 20 minutes, 8 in 60 minutes with any one of the following, right? With any of the following. So it could be number 1, a cervical dilatation of more than or equal to 3 centimeters. Or it can be what? Since it has to be any, it can be a cervical length of less than 20 mm or 2 centimeters. Third, it can be what? It can be a cervical length which is between 20 to 30 mm, between 2 to 3 centimeters with a positive FFN. So if my patient has these contractions with any one of the following, this is how we make diagnosis of preterm labor. So this is what is the most recent way of diagnosing PTL. But if you go to the earlier classifications or diagnostic criteria where ultrasound was not readily available to assess cervical length, at that time we used to have a criteria of 80% effaced cervix. So this is an older criteria. And along with 80% effaced, cervix, there was a criteria of 2 centimeter cervical dilatation. So actually, this can also be considered as true statement if we look at the older guidelines. Okay, the newer ones I've given to you, which is what is also in your class notes. Take now. We have two options which seem to be wrong. Cervix more than 1 centimeter was not a criteria, and cervix directed posteriorly is also not a criteria. Among the two, the best answer is to go with D. The position of the cervix is never a criteria, not an old, not a new criteria to say that whether the woman is having a labor or not. Okay, so position does not define diagnosis of labor, whether preterm or term. So that is the best answer to go with. But yes, I'm telling you, older criteria was 2 centimeter dilated and 80% effaced. So when they say more than 1 centimeter, it means 2 centimeter. Yes, so that is why this is what I'm saying was the older criteria. 2 centimeter and 80% effaced. But since now we have ultrasounds readily available, we don't use this criteria. Now we use the criteria for cervical length or cervical dilatation. Okay? Chalo. So which of the following is more commonly associated with Kalman syndrome? So अभी हमने एक और question किया था. Kalman's is a typical example of hypogonadotropic hypogonadism. Yes? So you all know the reason here. The reason is a mutation in a gene which was called as CAL1. The new name for the same gene is anosmin1 or anos1. Right? So we've done this in class. And this genetic mutation classically causes hypogonadotropic hypogonadism and anosmia. That's the answer. The reason for hypogonadotropic hypogonadism is failure of neuron migration. Yes, so failure of neuron migration. So the neurons which secrete GnRH, yes, you all know they are going to arise from the olfactory placode. Yes, and from the olfactory placode, they are going to show migration to hypothalamus. So to the medial part of the hypothalamus, right? Now what happens is with the mutation in anos1 gene, this migration is what is going to not happen. So as a result of which, in Kalman's there is no GnRH. So if there is no GnRH, there is no stimulus to the pituitary to release LH and FSH. So LH and FSH levels would be very low. There will be no stimulus to the testes. So as a result of which, these boys, when they are born, they are going to have very small testes. They can also have cryptorchidism, okay, and they can also have a microphallus, right? So because of low levels of stimulus to the testes and no release of testosterone. Apart from this, you should know that Kalman syndrome is associated as an X-linked inheritance. So if it is X-linked inheritance, it is more common in boys as compared to girls. So it can happen in girls as well, where it is going to what cause? Primary amenorrhea. So Kalman's is a cause of primary amenorrhea in girls. But as such, the disease is more common in boys because of the inheritance pattern. Now these boys who have Kalman syndrome, you know, we usually say they have renal agenesis also on one side, right? They can also have synkinesia. You should know this. Okay. So synkinesia kya hota hai? These are mirror movements, right? So they have renal agenesis, they have synkinesia. They have midline facial defects like a cleft palate or a cleft lip, right? So midline facial defects, and they can have skeletal abnormalities as well. Okay. The skeletal abnormalities can be in the form of syndactyly. So now if you see syndactyly is also one of the options here, but this is not the answer because they are trying to ask us what is more commonly seen. So you should definitely answer it as anosmia. Okay. Alright, so this was an easy one. Which of the following constitutes the modified BPP? Something which we have routinely done and I'm not going to discuss here in details. So modified BPP has only two components, yes, and those are amniotic fluid and non-stress test, right? So NST and amniotic fluid are the components. One is going to tell you about acute hypoxia to the baby, and the other, that is amniotic fluid, is going to tell you about chronic hypoxia or uteroplacental insufficiency. So this is what we do if a lady comes to us with reduced fetal movements. Okay, we are going to make her undergo a modified BPP. And if modified BPP turns out to be abnormal, so any one of the parameters, whether it is amniotic fluid index or it is a non-stress test, if any of the parameters is abnormal, then she should go for a complete biophysical profile, yes, which is also called as the Manning score. Absolutely right, which is done for a span of 30 minutes using an ultrasound. Okay, chalo, let's go to the next question. Okay, so which of the following is not cost effective for routine screening, right, in pregnant women? So do we do HIV testing routinely? Yes. And what is the method we use? We call it as opt-out testing, okay, which means we will prescribe HIV test to all pregnant women at their first antenatal visit. She may get it done, she may not get it done, but we have to prescribe. Similarly, do we look for HBS antigen? Yes, right. So HBS antigen screening is also done. Do we do a VDRL? Yes, which you know is for syphilis. Echo. So that is the answer here. Echo is not something that is used for routine screening in pregnant women. You only do it if she is high risk. For example, if she has pre-gestational diabetes, okay, then yes, you should definitely do it, especially if the HbA1c levels are more than 6.5. Yes. So if the HbA1c levels are raised, then you should definitely do the echo testing. Also, high risk matlab if either of the parents has a known case of heart disease. So you should all know that if father or mother has heart disease, then the possibility of heart disease in the baby also increases. So only if the mother is high risk will you advise her to undergo a echo scanning. Otherwise it is not required. The ideal time for echo is again between 18 to 24 weeks, and here we're talking about fetal echo. What about echo in the mother? Again, you don't do echo for the mother routinely. It is only to be done if she is a known case of heart disease or if you suspect heart disease in the mother herself. Alright? Chalo. Again, an easy question. High risk HPV does not cause laryngeal papillomatosis, right? Laryngeal papillomatosis and genital warts are caused by what? Yes. HPV 6 and 11. Whereas anal cancer, oral cancer, right? In fact, we say oropharyngeal, penile cancer, right? Cervical cancer, vaginal or vulval cancer, right? So these are all the malignancies that are done by high-risk HPVs, and you know the two genes that they knock out. So P53 and RB gene, yes? And we say E6 is what is going to knock out the P53 gene, and E7 is what is going to knock out the E6 is what is going to knock out the P53 gene, I'm sorry, while E7 is what is going to knock out the RB gene. Yes, and I have told you this before, that when E6 knocks out P53 gene of the host, the cell becomes what? The cell becomes immortal. Whereas when it knocks out the RB gene of the host, what is going to happen? The cell is now going to multiply as well, right? So it becomes, so for malignancy, you know, it is both E6 and E7 genes that are going to, or proteins of the viral proteins which will cause the malignancy. But if we have to mark one, we should mark E7, right? So agar ek mark karna hai, it should be E7. Now let's go on to the next question. So by giving 5-alpha reductase inhibitors, what is going to happen, right? So what does 5-alpha reductase do? So testosterone is converted into the more active form, right? So it is more potent. Dihydrotestosterone is actually the most potent form of androgen, and this conversion is what is done by 5-alpha reductase. So if you give a 5-alpha reductase inhibitor, what are the examples? Like finasteride. Yes. So the example is like finasteride. So if we give those drugs, what is going to happen? So what is going to happen is that testosterone levels will slightly increase. They don't decrease. So they can slightly increase, or some say unchanged, but not decreased for sure. So this is wrong. And as a result of which, what will happen to the feedback inhibition? That will increase. So testosterone is going to do a feedback inhibition to LH and FSH. So what will happen to LH, FSH? The LH and FSH values are going to reduce. So that is the best answer here. Prolactin, no, it doesn't do anything to the levels of prolactin, right? Okay, let's look at the next question now. Kassovitz rule is related to, yes, so this is easy. This is related to the late congenital syphilis. Yes, so this is related to late congenital syphilis. इसका मतलब क्या है कि as maternal disease progresses, है ना? So as maternal disease progresses, what will happen to the vertical transmission? It will reduce, right? So risk of vertical transmission decreases. So what happens with every subsequent pregnancy? The outcome or the pregnancy will be taken to a higher gestational age. For example, she may have her first miscarriage, let's say at 18 weeks. Then in the next pregnancy, this will go on to 26 weeks. I'm just giving you an example. In the next pregnancy, it may go on to 32 weeks. And finally, if she keeps getting pregnant, she will give birth to a live born baby. Yes. So with every subsequent pregnancy, the pregnancy is going to a higher gestational age. Also here I want to definitely tell you, because you do this mistake, syphilis does not cause recurrent early abortions. Only the first one is actually a abortion. If we look further, it actually causes stillbirths, right? So more classically, it will cause stillbirths because the pregnancy keeps advancing to a higher gestational age. So please remember, syphilis does not cause early recurrent abortions. Infections don't cause recurrent abortions. Okay? Chalo. Let's go further now. So this is again something we've done in great detail in class. Pathogenesis of preeclampsia. So you all know that there is going to be endothelial injury. Yes. Why? Because the hypoxic placenta is going to cause this endothelial injury. And why is there a hypoxic placenta? Because of absent vascular remodeling. So because of absent vascular remodeling, the placenta becomes hypoxic and it starts releasing certain mediators, yes, which will cause endothelial injury, right? So anti-angiogenic factors beta will increase, right? So factors like SENG, so soluble endoglin, or SFLT1, right? FMS like tyrosine kinase 1. So these are anti-angiogenic factors, they will increase. Whereas angiogenic factors, कौन से होते हैं? Yes, so VEGF or placental growth factor, they will decrease. So angiogenic factors will decrease. What else? Vasodilators will decrease because of endothelial injury. So there will be low levels of nitric oxide and there will be low levels of PGI2. Whereas vasoconstrictors will increase, right? So there is increase in the levels of thromboxane. Yes, so remember these, and there is also increase in the levels of endothelin 1. So those are the changes. So if we look at this, the answer is going to be D. There is not a decrease in thromboxane A2 levels. In fact, it is going to increase. And there is not an increase in PGI2, it will decrease. So if PGI2 decreases and thromboxane increases, the ratio will also decrease. Okay, so that is the answer. Okay. So which of the following is incorrect regarding MagSelf? Again, this is directly from your class notes. Yes, so we have done this. MagSelf should be given for 24 hours after a convulsion. Yes, so 24 hours after the last seizure or delivery, whichever happens later. So you count 24 hours from what happens later. So अगर delivery बाद में गई हुई है, you count 24 hours from delivery. If she is thrown a seizure even after her delivery, then you count 24 hours from the last seizure. Then the loading dose has to be given in a woman with renal failure or deranged RFTs. It is the maintenance dose which will need changes. So this is also a true statement. Then MagSelf is a neuroprotective drug, absolutely right. And how it does the neuroprotection is it stabilizes the neuron membrane. Yes, so the neuron membrane or membrane potential is stabilized. It also stabilizes the circulation. Yes, the cerebral circulation. It also has what? Rather it prevents the oxidative injury. Yes, so it protects from oxidative injury. And how else? Yes, it has anti-inflammatory action. Yes, so it also protects from inflammatory injury. So these are the mechanisms how it is going to be a neuroprotective agent. So what is the answer? MagSelf covers seizures and hypertension simultaneously. This is the answer. We have taught you repeatedly that MagSelf is not an antihypertensive drug. Okay, it may have some effects on blood pressure at very high doses or very high serum levels, but not in the therapeutic range. Yes, therapeutic range is 4 to 7 milliequivalents. And in this range, it has no effect on the blood pressure. So you have to give a separate antihypertensive to your patient to manage the blood pressure. Okay. Then regarding postpartum hemorrhage, which of the following is incorrect? So sorry, this is a wrong sign. This was increased. So loss of more than 500 ml in vaginal delivery, which is a true statement. Okay, and the incorrect statement is actually B. The initial replacement should never be with colloids. We have already taught you that initial treatment has to be with crystalloids, and it is going to be isotonic crystalloids. And how much do we replace? Not 4 times the amount of blood loss. It's actually 2 times the amount of blood loss. The safe upper limit is around 3 liters. That is what you can replace, because after that you have to keep a check on electrolytes, on coagulation factors, right? Then chorioamnionitis, multiple pregnancy, prolonged labor are risk factors. Absolutely true. We have told you that you have to know the risk factors for PPH. It's important. Option D is also true. So if you have to calculate how much, you are going to replace, or the blood volume lost is by adding 500 ml for each 3% drop in the hematocrit. Okay. So answer is B. Now, the following statements are true regarding Manning score, except. So Manning score we just did is BPP. So it includes breathing movement, tone, FHR, amniotic fluid volume. This is an absolutely true statement. So it has 5 components. Okay. It tells us about fetal outcome and fetal pH. Yes. So and that is why you're using it. You wanted to rule out any acute injury or hypoxic injury to the fetus. Yes. So a score of less than 4 is consistent with fetal pH less than 7.2. Yes. And a score less than 2 is 100% predictive of fetal acidemia. This is absolutely true. That is why we teach you that if the score is less than or equal to 4, then you have to do a immediate TOP, termination of pregnancy. Okay. The answer is actually D. Score is consistent with so ये question उल्टा हो गया. So इसमें था score is inconsistent. This was the statement. So please correct the statement. Score is inconsistent with fetal pH at different gestational ages. So this is what is the answer here. Because actually, what is the true statement? This true statement is score is consistent. So the score is pretty consistent for fetal pH at different gestational ages. Okay, it is consistent with pH throughout the gestational age. In the real exam, the statement was the score is inconsistent. That is why it is the answer, because we have to tell about the wrong statement. Okay, so remember, score is consistent with fetal pH across gestational age. So this is what is the true statement. Okay. Remember, a score of more than or equal to 8 means no fetal acidosis, no hypoxia. Okay, the brain is well perfused, right? A score which is 6 by 10 with normal amniotic fluid is what is considered as equivocal, and you need to repeat it within 24 hours. And as I said above, if the score is less than or equal to 4, it needs immediate termination, which is going to be by a cesarean section. Okay? Okay. So this was a question where the woman was a known case of breast cancer, and she has undergone a mastectomy, and she has been on tamoxifen therapy. The question also said she is disease free for 5 years. Yes, that was also there in the question. So she's been taking tamoxifen for a span of 5 years. Now she wants to conceive. Yes, so that was the exact MCQ, right? That she is now disease free for 5 years and now she wants to conceive. What should you do? What should be the contraceptive advice? So advice is that once she wants to conceive and you've already given tamoxifen for 5 years, you can now stop tamoxifen. So you need not continue it. But please understand that there has to be a minimum gap of 2 months between stopping of tamoxifen and conceiving or conception. So no need for contraceptive is absolutely wrong. While she is on tamoxifen, you have to ensure that she doesn't conceive. So she needs to be on some contraceptive agent. She also needs to be on a contraceptive agent for 2 months, a minimum of 2 months after stopping tamoxifen. And since exactly 2 months is not in the options and the minimum requirement is 2 months, here the answer will become 3 months. It cannot be 1 because minimum requirement is 2 months. Okay? Then, regarding management of diabetic women in labor, what is incorrect? So now please understand this. This is a question in general about diabetes in pregnancy, and every statement by itself is an MCQ. Let's look at this. Capillary blood glucose levels are to be maintained at 100 milligrams. This is an absolutely true statement, and it is there in your notes where we have given you about the target blood glucose levels. Regular insulin is given by infusion pumps. It's also true. Okay? Now, elective cesarean has no effect in reducing the incidence of brachial plexus injury. So please understand, diabetes itself, okay, diabetes itself is not an indication for cesarean, because just because a woman has diabetes, cesarean section will not help anywhere. Yes, cesarean section will help in reducing brachial plexus injury only in patients with macrosomia. So elective cesarean will reduce brachial plexus injury, but this is when you are talking about macrosomia, not about diabetes in general. So actually option A is a true statement. You don't have to do cesarean sections for all women. So if you feel 3 kg is more and you do a cesarean, that's wrong. That is why we said, what is the cutoff to decide on cesarean section? So if the estimated birth weight of the baby is more than or equal to 4.5 kgs, yes, this is what we said is a direct indication for CS. Yes, so please remember the cutoff for macrosomia is 4 kg. Direct indication for CS in a diabetic pregnancy is estimated birth weight which is more than or equal to 4.5 kgs. And what is the direct indication for CS in non-diabetic? It is 5 kgs. There the cutoff is 5. So actually the answer here is B. GDM patient को हम क्या करते हैं? Again, this is something I've told you in your class notes, that the night dose of insulin has to be given. Okay, whereas the morning dose before induction is omitted. In fact, I have taught you the reason why as well. So morning dose को क्यों admit करते हैं? Because in labor the insulin requirement is going to reduce. So you omit the morning dose, you induce the patient, and you keep a close watch on blood sugar. So we do monitoring every 1 to 2 hourly, and only if required will you give her insulin. Okay? Okay, so this is a very simple question. It's actually an anatomy question. So from adluminal to luminal jab aap jate ho, what would be the order? So all you have to know here is that as you go from the adluminal compartment close to the luminal compartment, the sperm, the sperms are going to mature. So adluminal में सबसे पास क्या होगा? Myoepithelial cells. So this is number 1. Then it will be spermatogonia. Then it will be primary spermatocyte. फिर luminal में mature होते जाएंगे. So it will be at number 4. It will be secondary spermatocyte, and then it will be spermatid. So the option A is the correct. It's a very basic question. ऐसा कुछ नहीं कि इसमें anatomy में भी बहुत detail आने. You just have to know that as you go from adluminal to luminal, the maturation of the sperms is going to, or the sperms are going to get more and more mature. So immature forms are in the adluminal, while the mature forms are near the luminal compartment. All right. So this was one of the questions which was on the latest guidelines. So the WHO SAGE trial, right? So what is the SAGE trial? So this is actually a strategic advisory group of experts on immunization. Okay, strategic advisory group of experts on immunization. So they are giving this, and this actually came in the month of April, and in June they asked it in the exam, right? So April में ही ये guidelines आए हैं, and as per these guidelines, so these guidelines are based on the concept that the HPV vaccine has a very good protective rate. So even one dose is good. So if we increase the coverage of one dose itself, we can reduce the number of cervical cancers, right? So what is the recommendation? And they typically ask for women less than 15 years or girls less than 15 years. So please remember, it is recommended that girls who are between 9 to 14 years. So I'm telling you the latest guidelines of the SAGE trial. So if they are between 9 to 14 years, either 1 or 2 doses, right? So 1 or 2 doses are to be given. So actually that is the answer. Whereas if she is between 15 to 20, again it is 1 or 2 doses. Whereas if she is beyond 21 years of age, then she will receive 2 doses with 6 months interval. So those are the recommendations. So 1 or 2 doses between 9 to 14, 1 or 2 doses between 15 to 20, 2 doses beyond 21 years. Also, please remember, in immunocompromised patients like HIV, the SAGE trial says that they should be given 3 doses. If 3 is not possible, then a minimum of 2 doses. Right? So HIV में minimum 2 doses देना है, but if possible, give them 3 doses of the cervical cancer vaccine. ठीक है? So this is the SAGE trial. Okay. So this is a patient who is currently 37 years old. She has a history of breast cancer in the mother at 50 years and ovarian cancer in her sister at 40 years. So which means she is actually a case of what? Familial cancer syndrome. A very strong family history. Why? Because these malignancies are happening at a much younger age. Typically, the familial cancers will happen a decade earlier. Now, currently, she is using OCPs for contraception. What advice do you want to give her next? Because she is likely a case of familial cancer syndromes, the most important step here is getting her tested for BRCA gene because mutations, because this is what is going to decide the further management. Suppose she turns out to be BRCA positive, then you have to advise her what? You have to advise her prophylactic BSO as soon as family is complete. And till the time, can she use OCPs? Yes, OCPs can be used. So there is no need to immediately stop OCPs. They will actually reduce the risk of ovarian cancer in her. Although taking OCPs or current OCP use may increase the risk of breast cancer, but the guidelines say that they are not contraindicated. Okay, so the most important step here is BRCA testing, and further decision would be based on BRCA testing. Okay. Now, which of the following cerclage procedure would be done in a non-pregnant female with cervical incompetence? So generally, whenever we talk about cervical incompetence, we talk about in pregnancy, and we talk about surgery or cerclage during pregnancy, right? And majority of times when you talk during pregnancy, you are doing a vaginal cerclage, right? So what are the most common ones that we use? So McDonald's and Shirodkar's. Yes, these are the two names that you know, McDonald's, Shirodkar's. Now please remember, lash and lash is a cerclage, which is again a vaginal cerclage, and it can be done in pregnant women. It can be done in the non-pregnant women as well. But this is not the answer here, right? So lash and lash kar sakte ho, no doubt, right? Worm cerclage is again something that we do as a vaginal cerclage, and it is done in pregnancy. So here the question is about non-pregnant. So this goes out of question. Benson and Durfee were actually the first people to give trans-abdominal cerclage. So this can be used again in pregnant and non-pregnant. Now the question is, your patient is currently non-pregnant. What is the preferred treatment that you will give her? That was the question. Which of the following would be the treatment of choice for her, right? So it has to be a laparoscopic cerclage. Laparoscopic cerclage has a lot of advantages. It is minimally invasive. That's number one. Less hospital stay. Yes, and you can place the cerclage much higher. So through the transabdominal routes, the cerclage can be placed much higher, much more close to the internal os, and it becomes more effective, right? So laparoscopic cerclage will be more effective in terms of preterm labor or abortions, and that is going to be treatment of choice in the non-pregnant woman. So the answer here is actually laparoscopic. Okay? Okay. So this is a very core, teratogen ka upar question hai. I think everybody would have done it right. Which of the following drug is contraindicated in psychiatric disorders in pregnancy? So you all know कि lithium has to be contraindicated. You are not going to give lithium to a pregnant woman, right? And then this was another question which I feel is, yes, weird, but believe me, this is not a question which decides your rank. So even toppers have done this wrong, so don't worry about it. What is the half-life of letrozole? It is actually 48 hours. But why should you know this? The reason why should you know this is because, letrozole is being used for ovulation induction. Yes. And whenever a drug is being used for ovulation induction, one of the most important thing that comes to our mind is that it should not be teratogenic. So the reason why we want you to know that it has a short half-life is you're only giving it for 5 days. Yes. So usually, you'll give it from day 2 to day 7. Yes. So you give it for 5 days, and as a result of which, or we can just simply put it as day 3 to day 7, right? So if you give it for 5 days, it will be quickly eliminated. So by the time the woman is in her fertile phase, by the time she will conceive, because of the short half-life, the letrozole is excreted. Yes. So, so this is the reason why we want you to know that it has a short half-life. It will be excreted, and the chances that it will be causing any harm to the baby is going to be very, very less. So it has not shown to cause any teratogenic effects on the fetus. So rather than mugging up the answer, you should know why it is a question, or why is it important for us to know this, right? Chalo. I hope you find the discussion useful, and I wish you all the very best for your November exams. Please go through the PYQs. They're important. And, wish you the best for your exams, both INICET as well as NEETPG. Take care, everyone.